Good afternoon, everyone, and welcome to the Veteran Health and Wellness Foundation's Veterans Lived Experience Series event. My name is Dr. Evelyn Lewis, and I'm the president and chair of the foundation and your host for today's event. The foundation is a nonprofit 501c3 charitable entity, and it was established by military veterans with expertise in the area of health, wellness, and healthcare delivery intersect with the social determinants of health and military culture. What we do is embodied in our mission, which is to build, educate, and maintain resource networks to support the complex physical, social, and emotional needs of veteran communities across our nation. Our vision seeks to expand communities that possess the knowledge and capacity to not only identify and address service-related health challenges, but also to embrace, support, and empower the veterans and their families who experience them. Bottom line up top, for veterans and their families to be their best selves, the foundation strives to expand opportunities for them to live healthy and well lives that are undiminished by their service-related health concerns. So as you all know who are joining us, today's topic is inflammatory bowel disease, or IBD, in veterans. Here we'll dive into this chronic illness and see the impact that it may have on one's military career, their personal relationships, and the ability to find work and to live one's best life once they leave the military. My guests today are Mr. Carlos Cabrera, who is a veteran Marine, and Dr. Marie Borum. She is board certified in internal medicine, gastroenterology, and geriatric medicine. And she is the director of the Division of Gastroenterology and Liver Diseases and a professor at the George Washington University School of Medicine and Health Sciences. She's also the director of the Gastroenterology Fellowship and an associate professor of public health at the George Washington University of Public Health and Health Services. We may also be joined by Dr. Samuel Arce. He is a primary care physician, internist, and was the former chair of the National Hispanic Medical Association Board of Directors. Primary provider located in Richmond Hill, New York, and has several other practices in the New York area with 41 years of experience. So now what I want to do is I'm going to turn it over to Dr. Borum for a few minutes so that she can just give us a little bit of an overview of what IBD is and the impact that it has on the health of those it affects. So Dr. Borum, could you just tell us a little bit about that in layman's terms so that we can really understand what we'll be talking about today? And then I'll talk with Mr. Cabrera about his own personal experience.
Thank you so much for that introduction, and I really appreciate the opportunity to be here, and I feel honored to be on the panel with you and Mr. Cabrera. Inflammatory bowel disease is an area of interest of mine, not only from a clinical standpoint, but also from a research and health delivery standpoint. And one of the things about inflammatory bowel disease is that people sometimes get it confused with other conditions. Inflammatory bowel disease is a circumstance in which there is inflammation in the gastrointestinal tract that is something that is chronic and it can relapse. But one of the many things that has been so exciting in the recent years is we have medications and therapeutic opportunities to make this disease something that is in remission, that is controlled, and that allows for people to live their optimum selves. Inflammatory bowel disease are several different entities, but the primary ones that people will hear about include Crohn's disease and ulcerative colitis. Those are the two most common ones. There are some other subcategories, but those are the ones that can affect us significantly, chronically, and we need to address them. Crohn's disease can involve inflammation that can occur from the mouth all the way to the rectum. Ulcerative colitis affects only the colon. But what has been so interesting for us for so many years is that it has historically been thought to be conditions that only exist primarily in certain communities. And what we have learned over the past number of years is that Crohn's disease is something that impacts all communities, both genders, and is increasingly recognized around the world, and certainly more recognized in the United States.
Well, thank you for that overview, because I think it's very important for everyone to know where we're starting from with this conversation. And so with that information, I wanted to invite Carlos, Mr. Cabrera, to talk about his personal experience with the disease. When it occurred, when you were on active duty, how it impacted your service, and what you've been able to do since getting out, or not been able to do since getting out and having this disease have its flare-ups.
Good afternoon, everybody. Ulcerative colitis, I was diagnosed with after the military, inside the military. Prior to getting out, I got a lacerated spleen grade 2 with no physical blow or trauma, and that's kind of where my gut problem started. In 2017, I started to go to school, and that's when my symptoms started to show in the beginning. I started to push them aside. I minimized my symptoms. During that time, I was weightlifting. So if I had diarrhea, I would say it was the protein poops. Or if I had a little bit of blood on wipe, I would say, oh, I just had a rough bathroom session, and then I would just keep going the same way. It really wasn't until I started filling the bowl up, the toilet bowl with blood, that I started to, take this seriously. Fast forward 2018, I finally got my associate's degree in college, but by then my symptoms already were onto the moderate, almost severe side of ulcerative colitis. That means that I had a lot of sense of urgency. I was going to the bathroom at least 12 to 15 times a day. And during this, it would hit me in traffic, it would hit me driving, it would hit me in the grocery store. It made my mental go really down because I was just walking around with anxiety all the time. I never knew when it would attack. I never knew what I would have to eat to get it right. I just knew that I had something that was permanent, and I didn't really have the resources then to fight it. But I finally got my associate's degree. I transferred to George Mason University. There, I wanted to study criminology, but during that whole month, I end up catching a sinus infection, bronchitis, and then I'm fighting the ulcerative colitis flare at the same time. So I have to drop out on the last day of tuition refund, and I had to be bed rest for about 3 months. And during this time, I experienced a lot of pain and cramping, painful bathroom usage, a lot of blood and mucus and stool. I went to the bathroom at least 25 to 30 times a day. I barely ate. I suffered extreme weight loss. I went from 160 to 120, and I isolated myself pretty much from everybody, my parents, my significant other at the time, and I was scared because I didn't know what I was gonna do. Something just came out of nowhere and just shifted my life completely, just put it on pause. And after those few months of bed rest, I started to feel a little better, and I just started working out. I started to go on social media. I looked at support groups for ulcerative colitis, inflammatory bowel disease, IBD, and I joined them. And I would watch people talk about their troubles with IBD, advocating, and I never said anything, but it kind of motivated me to want to do it. And then eventually, once I felt it was right, I came out to all my family and friends on social media. Um, I told them what was going on, what I was going through with my ulcerative colitis, and I wasn't doing it for pity or anything. I was just doing it because I was so tired of being isolated. I was so tired of being alone, scared, not knowing what was going on. But I knew that if I talked about what I was going through, just like the people in those support groups, I would kind of get support as well. And when I did that, the support I received was almost positively overwhelming. I had people hitting me in my DMs, replying to the post itself, and I had people, family that I didn't even talk to for a while, hitting me up, trying to see how they could, help me and what they could do for me. And that kind of sparked my wanting to continue that, to educate myself and to educate the people around me. I started posting on social media using the hashtags ulcerative colitis, IBD, inflammatory bowel disease. And through that, I was found by a man named Jordan McConnell, and he asked to interview me for his podcast called Crohn's Veteran. And at the end of that, I asked him if he needed any help with that. And a week later, he hit me back saying, welcoming me to the podcast. I became a podcast host. And from that, I found our other co-host. We would interview IBDers, share their stories, and I met so many IBDers on there that went through the worst of the worst. And every time I had an interview, I felt like I myself had my own personal problems, but I pushed my own personal problems just so that I could advocate and share their stories. And I'm so happy I did that because every time I listened to their stories, I got a little bit of something and I felt connected to them because you, in a sense, every IBDer kind of goes through the same thing, but they have different stories. Um, and honestly, it just helped me feel more connected. It helped me feel not alone in this world fighting this disease. And through that, through the podcast, we interviewed the lead ambassador at the time for COCHI, Color of Crohn's and Chronic Illness. And she asked us at the end of the interview to become ambassadors. And I agreed. After the podcast ended, I just continued advocating through COCHI and raising awareness.
Well, I'm going to ask you a little bit more about coaching and advocacy in a few minutes. But I wanted to go back to Dr. Boren for a second, because during your conversation there, you mentioned a lot about sort of isolating yourself up until you became this person who sought out others, who began participating in an advocacy role, et cetera. So I wanted to ask Dr. Boren in terms of the people that you've had as patients with this disease. Is that something that's common among them in terms of how they feel about their disease? Do they isolate themselves? Do you get them speaking about being lonely or feeling alone?
Such a very important aspect of this condition that needs to be spoken about more often. And I really commend and congratulate Mr. Cabrera for coming out and speaking so openly about his condition and advocating for others. Because when someone has gastrointestinal symptoms, including abdominal pain, diarrhea, weight loss, it becomes a circumstance that can be all-consuming and then subsequently isolating. It's particularly difficult when people are not sure what they have. It's bad enough to have a condition which is chronic that one is trying to get control over. It's particularly tough if you don't know what it is. And in the beginning, I have found that sometimes people will come to me after having months or even years of intermittent symptoms and have never had an evaluation to determine the cause of their concerns. So historically, this condition has been thought to only occur in those people, in people of European heritage. And in the United States, it was generally considered to be a condition that only happens in whites. But one of the things that was a consequence of that misinformation was that people of color, both African Americans and Latinos, did not get diagnosed as readily or as often as others. And it became even more isolating when you weren't certain what it was, when people were not understanding the severity of your symptoms and not getting a diagnosis. And if you don't get a diagnosis, we don't get adequate treatment or intervention. So in general, across the board, this condition can be very isolating because the symptoms can be dramatic. The weight loss that Mr. Cabrera mentioned is something that is not unusual when someone has significant inflammation occurring. And the weight loss, despite everything one may try to do with their diet or with medications, sometimes is persistent until we're able to get it under control. One of the fascinating things that I have noticed over the years is when someone comes and we talk about their symptoms and their concerns and their illness, and I will ask if they have someone in their family or do they know of anybody who has a similar circumstance. Very often people will say no, but not until they begin to open up and talk to family and friends do they realize that many people may have it, because this is not a set of symptoms that people will often readily talk about. And once you find that others may have the condition, you find that it's easier to get help and to get support. When I think of the patients that I've seen recently, I can just mention as an example one young man that I just saw who had at least 4 to 5 years of having symptoms where he wasn't taken as seriously as those of us who are here today would take his symptoms. He was not certain what he had. People doubted the severity. And not until we saw him in the hospital were we able to ultimately, after years and years of concerns, find out that he had Crohn's disease. When we told him he had Crohn's disease, when we let him know that this was something that we can address and take care of, he became quite tearful. And he became tearful not because he was scared of the disease. He became tearful because he finally had a diagnosis, that he was believed, that he could be open about it, and he could talk about it. Then at the same, not too many months later, there was another person that I was asked to see, and he was hospitalized for profound depression. And it turns out his depression was because of his isolation, because of the severity of this disease, because not being believed when he was talking about the pain that people couldn't measure or observe. And his profound depression prompted his hospitalization, but his diagnosis allowed him to get better. And so there are many, many stories that I hear and that I see every day, or at least every week, of people not only having the conditions related to their symptoms in their GI tract, but the associated concerns of isolation, of anxiety, of depression, that we must also simultaneously address.
Thank you. That leads me to another question for you, Mr. Cabrera, and that is, you heard Dr. Borum talking about the cases that she has worked with, or some of the stories from patients that she has had. And one of the things was sort of one of the longitudinal themes around that was psychological issues, depression, those types of things. What was your experience with that? As we think about this disease and some of the things that Dr. Borum has said, as well as some of the other patients that I've spoken to with a diagnosis of IBD, particularly if they were African American or Latino, have mentioned that they had a long journey, a long road to their disease being diagnosed. You were fortunate in that it didn't take you several years, 5, 10, 12 years to get your diagnosis. You got it relatively quickly when you began to have the symptoms, but yet you still were a bit withdrawn before discussing it with other people and family members. During that time, and even now that you, as you say, have come out and you talk about your disease, you actually have become an ambassador to help others. Do you still, or did you ever have to deal with any psychological, behavioral health, mental issues around depression or anxiety as it related to your diagnosis of IBD?
I would say that I did experience some psychological problems such as depression. Coming to my diagnosis, honestly, I wasn't really trying to put my mind to it as much. I was just trying to just find out what's wrong with me and then just keep pushing forward. It really wasn't until I started experiencing symptoms that the actual depression actually sank in. Me being bed rest for those months, I actually was depressed that whole time. Being isolated, being by myself, that it made me even more depressed. I cried a lot. During that time, I didn't have anything to do but just be there. I didn't journal. I didn't meditate. I was just in bed because I didn't have energy for anything. But going forward, once I was on the podcast, we were able to talk about, some things that we do for our mental health. And one of the things that I found for myself that was very useful was meditation and journaling. Some things that I still do to today. Also, I feel like cannabis kind of helped me in the psychological part as well, because even though I was hurting, I would use cannabis medicinally, and it would boost my moods. It would help me with my appetite, and it would make me feel better. But for anybody who is experiencing psychological troubles, I honestly just say getting it all out there on paper, on video, on voice message, whatever, and just reading it, listening to it, seeing where that hurt is, seeing where that depression is coming from, and then working at it to get better.
Dr. Borum, I just heard him mention some of the things that he used to help him sort of get through some of the periods of depression or anxiety around this disease. What are some of the treatments? There are mainstream treatments, I know. He mentioned cannabis. Are there other things that are used to treat this disease, either combined or independently?
That question is so important, because one of the things that we have learned is that there are increasing amounts of research about our therapeutic options. We certainly have the traditional therapies that we have used for decades, and of the recent medications that have currently been developed that have made a profound effect on making sure that people can get control of their symptoms and that inflammation can go into remission. Once we're able to get the inflammatory process controlled, we have very good symptom control. And we have a circumstance that we all know and are so pleased about is that when we get symptom control, we have good clinical outcomes. But the important thing is that we don't just concentrate on the inflammatory process in the GI tract, because while that is the mainstay of all the symptoms and triggers so much else that can occur, because there are things that can occur outside of the GI tract that is associated with both ulcerative colitis and Crohn's that we also need to address. We have things like joint pain, liver involvement, eye involvement, skin rashes, and mental health concerns. And all of those, depending upon the severity, may in fact need to be addressed concurrently and separately. When we talk about our alternative options, we are fortunate at GW in that we have an integrative medicine program. And one of the things that there has been some research on when we look at our alternative therapies, we find that individually they may help a person with their symptom management, although it may not be consistently helpful for all people. One of the things that you heard Mr. Cabrera mention was the use of medicinal cannabis. And we have found that for some people in some chronic conditions, including circumstances of inflammatory bowel disease, that has helped as an adjunctive therapy. It is not traditionally recommended in our guidelines of our traditional therapeutic algorithm, but we have found that when we work jointly with our integrative medicine providers, that there are circumstances where medicinal cannabinoids help when it comes to abdominal pain and mental health issues. And one of the things that we have is when we have inflammatory bowel disease just irritating the GI system, maintaining an appetite and maintaining adequate absorption can be key to maintaining a good weight and your nutritional status as your body tries to heal. So that is one option that is often helpful. But that's not the only one. Some of the other things that our integrative medicine program has looked at and some of our other providers have attempted to employ have been things like meditation. That has been very helpful. There are also circumstances that we have found that probiotics are helpful in certain circumstances of inflammatory bowel disease and in certain circumstances of ulcerative colitis, particularly those individuals who may have had to have surgery. And when we found that some of the studies show that probiotics are addressing the intestinal bacteria concentration or the microbiome that people are now talking about, we have now been able to, and some people have extrapolated beyond the very specific circumstances to thinking about using probiotics in certain treatment regimens. I caution, though, is because when people are on certain medications, immunosuppressants, we may not want to use probiotics, but things like cannabis, things like meditation, things like acupuncture, acupressure, and probiotics have really begun to be part of our considerations because we want to take care of the whole person and not just the gastrointestinal tract and not just the colon. So in fact, there are many areas that are being investigated now, and importantly so, we're making progress of figuring out how we can fit those in to our usual course of treatment.
Well, thank you for explaining a bit more about how all of these things can work together as well as independently. Another question for you that has come up in terms of, reading about this disease, talking with others who have it, et cetera. Are there specific risk factors that are related to getting IBD? I've read that, babies who are nursed or breastfed have, 30–40% less risk of getting a disease like IBD. How does that pan out in the real world? Is that actually what happens? Are they protected because of some of the, the benefits of breast milk? And if so, how would we speak to that to mothers, who are delivering and bringing babies into the world?
I've been trying to gain traction on understanding the risk factors for IBD for many years, as everybody in the audience and certainly on the panel know. One of the things that has become very apparent is that the issue of genetics makes more of a difference than we had previously anticipated. We have found that people who have relatives with inflammatory bowel disease have an increased risk factor or increased risk for developing inflammatory bowel disease. We have found that not only does it cluster in families, but it certainly has been demonstrated to be an issue as we look at studies that have actually involved twins. So we're able to say that genetically there can be a predisposition and a clear risk factor. We certainly have to gain more information in that arena. The other risk factor that people have talked about when it comes to the individual is that indeed at this stage in our understanding, we recognize that whites have a higher risk than other minority groups for both ulcerative colitis and Crohn's, but minority groups have been increasingly recognized and as having increased incidence of Crohn's and ulcerative colitis. Trying to figure out the genetics of those predispositions is something that is ongoing, and some really impressive investigators in the United States and globally have begun to make headway in understanding about the genetic predisposition. But as we say that, there are people, you can imagine, in families that have similar genetic predisposition, but one person may express it and the other person doesn't. And people have been trying to figure out why that may be the case. And could it be exposure, for instance, breastfeeding, that could allow for one person to develop symptoms and one not? But that area in breastfeeding is something that is still being looked at because we're not quite sure whether it is a transient antibodies through the breast milk of the mother that are protective for people that are not long-standing, or is it the fact that that individual just happens to have a circumstance where their genes do not express themselves through the inflammatory process? As we look at issues that can predispose someone to inflammatory bowel disease, we really look at a Venn diagram where there are overlapping circumstances of not only the individual susceptibility, but also the environmental exposures and then triggers, because you may be exposed, but you may not also have a trigger to allow that to happen. So one of the studies that Dr. Lewis is likely alluding to are, when you look around the world, we find that people who are in industrialized countries versus countries that are developing may actually have a higher risk. And is that because of environmental exposures? Is that because of the type of food that is ingested? Is that because of certain infections that someone may be exposed to when they're little? Is that because of the environment that may be not as pristinely sterile as in some places as in others? And those are areas that we're certainly trying to sort out. So we look at factors that we can't control, genetics, and then we look at factors that we potentially can control. So there have been issues about whether diet predisposes people, but that has not been clearly sorted out. But there is, as you can imagine, ongoing interest and research. Look at whether certain infections that people are exposed to. We look at whether certain medications that people get exposed to can allow for inflammatory bowel disease to express itself. We also have found that people who already have the condition may have variable expression and different outcomes if there is smoking, if there is alcohol, or if there are other autoimmune conditions that are not controlled. So that's, I think, a very complicated answer to the fact that we know that there are multiple factors that are involved in the expression of ulcerative colitis and Crohn's, but we are looking very closely at diet, smoking, alcohol, and childhood exposures that may allow for these conditions to express themselves.
So, Mr. Cabrera, in light of what Dr. Borum was just talking about, when you received your diagnosis, did your doctors talk to you at all about how this might have come about? If you had any particular risk factors that they suspected might have contributed to you contracting this disease, like she was mentioning, environmental exposures, foods, diet, those kinds of things. Did anyone talk to you about those kinds of issues when you got the diagnosis of IBD?
I'd say no, but I figured it out on my own throughout my journey. I know that for when I got diagnosed, I asked my doctor if diet had a role to play in IBD, and he said no. But going through my journey, I found out that, what you put in your body actually does affect your IBD. I feel like I want to piggyback what Dr. Borum said about the probiotics. That was one of the things that I found that was really useful to restore my gut. For myself, I found that a lot of IBD patients, they go through the same motions as all the other patients. They exhaust all their medical options, and then they have to get surgery. On the other hand, I saw that I was on the board for that trend, but I didn't want to do that. So I had to reassess everything in my life. I wanted to get right. So I made sure that I had my sleep in check, my diet in check. I eliminated all triggers. I kept my stress low. Also, I incorporated probiotics. I would drink a probiotic drink that was non-dairy, so it wouldn't trigger my IBD. I would drink that every day. I would use anti-inflammatory foods to, put down inflammation in my body, and also exercising as well. I found that once I was clicking on all cylinders, body, sleep, diet, exercise, and spirit, I found that I was getting better with my ulcerative colitis.
Yeah, so in your experience with your journey and the things that you just talked about, You mentioned earlier about an organization called Kochi, and that you are an ambassador for that organization. So in your role there as an ambassador, as you meet or come into contact with others with this disease who may have had a more torturous course than you did initially, meaning maybe it has taken them, 10 years of suffering to get the initial diagnosis, to even begin the treatment and to do the things that you've done there. What do you do, and how do you speak to them? How do you help them go from that starting point to evolve to where you are now on your journey?
I bring them, I tell them to, attend the IBD together sessions, kind of therapeutic, get them together with all the IBDers, to let them know, that they're not alone. They'll see that all the IBDers talking, sharing their stories, being vulnerable and open. They'll start to do that more themselves. And then I tell them about taking care of themselves. You have to put yourself first, or your body's gonna make that decision for you. So it's better you do it on your own instead of your body doing it for you. Getting, your sleep right, getting a little bit of exercise. You don't have to go to the gym or anything, but just get your heart rate moving for at least 30 to 45 minutes. Eliminating all trigger foods. This is one thing that a lot of IBDers struggle with. Even till today at IBD events, I would see IBDers, going after their trigger foods, but we're all humans. We're not meant to be perfect all the time. We could eat our trigger foods, but I say that hold off on that until you're in remission. Stay strict on your diet. Essentially, I don't follow a diet. I just eat really clean and, with moderation. But if you are on a diet, follow that diet if it's working for you. If it's not, find something else or eat cleanly. Because I found that when I would do a diet, it would affect my mental really bad. But when I don't do a diet, but I just eat cleanly, just restrict all the triggers, but I eat what I want in a sense without the guilt.
Very good, very good. Dr. Bormes, he talked a little bit more about sort of enhancing a little bit from the patient side, the things that you talked about. What do you see as sort of the end game for this? Is there a cure for IBD? He mentioned that some of the folks that he's spoken with as an ambassador have found that they've gone, from one stage to the other and eventually led them to surgery, which he sought to avoid and has thus far. Does surgery cure it? Do they need to continue to avoid triggers even after they've had surgery? How does that work in regard to managing or curing the disease itself?
One of the things that we so very much want is a cure. But right now, we cannot say that there is a cure for inflammatory bowel disease, ulcerative colitis, or Crohn's disease. But one of the things we are very happy to be able to talk about is that we've made considerable advances in managing the disease and keeping people in remission, and what we are now calling sometimes deep remission. One of the ways we talk about remission in inflammatory bowel disease, both ulcerative colitis and Crohn's, is we talk about being in remission from a clinical standpoint, where symptoms are gone, when life has begun to get back to normal. But from a medical and patient perspective, we also want to make sure that we can get people into remission from the inflammatory side of things. We want to make sure that we can get that inflammation that is in the gastrointestinal tract that is contributing and triggering all of our symptoms. We want to make sure that inflammation is under control and also in remission. So we look for clinical remission and remission of the inflammation in the GI tract, which we call histologic remission. And we have found over the years with advancement of medications that people can get into remission and stay in remission for years and years, although traditionally this has been considered a condition in which there are a chronic circumstance in which there are periodic relapses. But we have been able to work with people so they get into prolonged remission and into deep remission. But that takes work for all of us. It takes work not only for your healthcare professional to be attuned and available to the changes and advancements in our therapeutic options. It also is so very important to do the very things that Mr. Cabrera has mentioned about understanding how your body reacts to diet. Because while officially we have not been able to support a particular diet for inflammatory bowel disease control, we do know, and people will be able to express the things that trigger them and the things that are important for them to avoid. And so it becomes very important and critically important for people to understand what goes in to their body and how that may affect their system. Because what may affect me may not affect you, but it's important for everybody to know what individually affects them. So as we talk about cures and as we talk about treatments, while we cannot say we can cure inflammatory bowel disease, what we can happily say is that when people get into remission, prolonged remission, we're able to say that their clinical outcomes can be similar to people in the general population, i.e. lifespan can be the same in those people who are in prolonged remission and work towards staying in remission as those people who don't have inflammatory bowel disease. That being said, I just wanted to add one more thing. I do want to add that it is important that we understand that not only is it critical that we make sure that our symptoms are under control, that our inflammation is under control, but we also understand that inflammatory bowel disease, while we want to make sure that our outcomes and our lifespan are as good and as long as they can be, we also have to recognize that both ulcerative colitis and Crohn's disease involving the colon can predispose you to have an increased risk for colon cancer. And so it's important that that screening be done regularly and more frequently than others. Because as long as we're doing that, we want to make sure that we stay healthy, not only from the inflammatory bowel disease standpoint, but we also take care of any other potential conditions that can be the result of IBD. And so as we look at cures, we're really looking at people going into remission and staying in remission, what can feel like a cure, but not just a cure as we define it in the traditional sense.
Thank you. One other question I have for you, in particular, we talked a little bit about this in the beginning where we mentioned that this disease, at least up to now, has typically impacted African Americans and Latinos far worse than their counterparts because a lot of times the diagnosis just wasn't made for any number of different reasons. One, the thought that it didn't occur in these populations, or two, it was manifesting in ways that it didn't focus or hone in on IBD because they had, a little bit of pain here, a little bit of pain there. Yes, they had some diarrhea, but there were other things going on also. And so most of us typically present to our primary care physicians prior to any specialists like yourself. What can primary care doctors do, or those in the ER do, if someone shows up in a sort of a crisis, sort of say. What can we do as primary care physicians? What would you recommend for them, such that they could, their awareness around this disease could be heightened, that they would be more suspicious if someone came to them with symptoms of IBD, but mild, accompanied with some of the other things that you mentioned? How would you speak to them about being a bit more suspicious when they get patients with those types of symptoms?
I think what is critical is that we have a multi-pronged approach to advancing awareness of inflammatory bowel disease. The organizations that Mr. Cabrera has been involved in are doing remarkable jobs in making sure that there's heightened awareness from an individual standpoint, allows for people to talk about it, to hear about it, and to understand about it. And once individuals understand that this condition may occur in them, in their family, or their friends, one can be an individual advocate. But I think what is also sometimes not frequently spoken about, but what is so important, is that those efforts for heightened awareness are also efforts that are going on from the medical standpoint. It is shameful when I see that there are people like myself, meaning gastroenterologists or specialists, who forget or are not as attuned to recognizing that inflammatory bowel disease occurs in all people. And so when we think that a specialist may not recognize and appreciate that inflammatory bowel disease, inflammatory bowel disease can occur in all people, we certainly understand that the primary care physician may not have the same awareness. So as we spread our wings to make sure that we have our medical community are aware, I just want to make sure that our primary care providers and our specialists alike keep inflammatory bowel disease as part of their consideration when someone comes in with abdominal pain, because their pain doesn't have to be catastrophic to have inflammatory bowel disease. The pain doesn't have to be severe, and it doesn't have to be constant to have inflammatory bowel disease. The symptoms may not be continuous to have inflammatory bowel disease, but making sure that you recognize that pain and change of bowel habits and weight loss and fatigue all can be part of the non-specific symptoms that can occur in ulcerative colitis and Crohn's disease. So I just want people to put that on the list of things that they think about, and not just think that it may be stress or irritable bowel syndrome or infection or gynecologic issue or genitourinary issue or a renal condition, which are all things that come up on the differential. But inflammatory bowel disease must be on the differential for everybody. At least think about it. And when our patients show up in the ER, which they may, it's important that we as providers, we as individuals, we as people who care, it's important that we make sure that we have resources and know those resources so that we can get appropriate referrals. I'd much rather have someone come to me because they have symptoms and people were thinking about inflammatory bowel disease and it not be, rather than people not coming to me because people didn't think that it was serious enough to warrant a specialty evaluation. We can't make a difference until we make sure we understand that this condition and these conditions occur frequently and occur in everybody.
Thank you. Carlos, as we come to a close for this discussion, I wanted to ask you and Dr. Borum both for some closing comments. And I'll start with you in regard to resources. One of the things that I think brings about some of the loneliness and distancing of people who have IBD is their lack of resources and understanding the disease or knowing that there are others who have it that they can have a conversation with. What are some resources, or where would you direct people to go to get additional information, to educate themselves? Because oftentimes we don't get enough from the doctors that we're seeing, or we don't get it in a way that we can digest it, that we really and truly understand it. So aside from recommending that they ask more questions of their providers when they get this diagnosis, as they should about anything, what other resources would you recommend for someone who has this who has this diagnosis?
I would recommend going online, depending on the information that they're looking for. If they're looking for something that's researched or academic, I'd say Google Scholar. I know I've used that before to do some research. I type in on Google just the question I'm looking for and pull up a website like Healthline or Health Monitor. Also social media. Social media has been a big one for me. I use the hashtags on Instagram, on Facebook. I use support groups, and on YouTube as well. I type in my question or whatever I'm looking for, but it doesn't matter where you get your information from, is as long as you're educating yourself and making sure that that information is correct, is that what matters.
Thank you. And Dr. Borum, from your end, what resources would you recommend or suggest for folks with this diagnosis, or for people who think they may have IBD but haven't yet been diagnosed? Do you have any specific resources that you could direct them to?
Right. I would like to add, in addition to what Mr. Cabrera has mentioned, is going to the website of Crohn's and Colitis Foundation. This was a small organization that started that now is an expansive organization that has headquarters in New York and regional headquarters in different parts of the country, and also other countries have similar organizations. Because the Crohn's and Colitis Foundation is a foundation that is actually quite unique, because we have physician members and we have patient members and advocates. And what is interesting is that it allows for not only for you to get information from them specifically, they can also provide you information if you want specific sources to look at the conditions that you are talking about. And also it allows for you to link to providers or to institutions in which inflammatory bowel disease is an area of interest, of research, and of caring. So the Crohn's and Colitis Foundation, I'd like to also put that on the list of places that people can go to get factual information that has been validated and has been resourced.
Well, thank you. And one other thing, Carlos, before we go, if you could provide the URL for COCHI. We know that that's a reliable source of information and advocacy for patients with this diagnosis. And so if you could provide the URL for that, I think that would be another good place for people to gather information.
Yes, the URL is COCCI.org, COCCI.org.
Great, thank you very much. And thank you, Dr. Borum and Mr. Cabrera, for your time today in talking about this issue, which has impacted many, many people. As I stated before when we started this conversation, I've talked to a number of folks with this disease, and ethnic minorities in particular, and their journeys have been really sort of horrible recounts of issues with this diagnosis. And so I thank you for bringing some additional clarity to this, some understanding of the things that they will experience or can experience, and where they might go for help, questions they might ask to make this more tolerable disease to work with, and how to express themselves and not isolate themselves when they do get a diagnosis like this. So again, thank you very much for your time today. This has been the Veterans Health and Wellness Foundation talking about the Veteran Lived Experience Series event. We will do the same thing next month in November. We're always the second Tuesday of the month from 1 to 2. And in the month of November, it is also known, as many of you probably know now, as Veterans Military Families Month. And during that time, not only will we have this information cast, as I call it, but we will also be doing a health fair in Silver Springs. It's called the Veteran Health, Wellness, and Information Expo. It's on November 5th from 10 in the morning to 2 in the afternoon at Silver Spring. If you go to our website and go to info@myvhwf.org, send us an email. We'll send you all the additional information that you might need. If you know veterans, if you are one, if you have family members, and they're in this area, in the DMV area, please provide them with this information. They can come by and get some invaluable information for themselves, help with filing for service-connected disabilities, information on how to register for healthcare at the VA if they're eligible. There'll be dental screenings and a whole slew of other additional screenings, like for diabetes, hypertension, weight management programs, et cetera. So again, thank you for your time. And thank you all for tuning in and listening to this. And we look forward to seeing you again in November. Thank you, Dr. Borum and Mr. Cabrera.
Thank you for having me.
Thank you for the invitation.
You're welcome. Thank you all and have a great rest of the week.